Welcome. My name is Alex Vaccaro, and it's an honor to speak at the Cervical Spine Research Society. I'm going to talk about an old myth. Oh, you have a pseudarthrosis, and therefore you can't play football, you can't play soccer, you can't participate in contact sports. My disclosures are listed in the program. I have no disclosures directly related to this presentation. So we all know that when we do an anterior cervical fusion, allograft, autograft, metal, without metal, we're going to have pseudarthrosis. It can be up to 20% for single level in a well-prepared cervical fusion bed. There's all different ways of evaluating, does the pseudarthrosis exist? The most sensitive way is a CT scan with fine cuts, but the literature is all over the place on what demonstrates a fusion. Do you see spreading of the spinous processes? Do you see any type of lucency? Do you see any type of motion? So replete, many articles written about it. But there's no consensus on how to manage someone that comes back to you and says, I feel great, and you see an obvious radiographic pseudarthrosis. So what do? You tell them not to do anything. You tell them not to slip. You tell them not to get into a motor vehicle. It's crazy. If it's a stable pseudarthrosis, it poses no threats. The first question I ask people is, why are you symptomatic? Some people think, well, you have nerve fibers, pain fibers that grow into the pseudarthrosis site. It's been identified there are nerve fibers, but they haven't identified specifically what type. Could it be fractures in the newly forming bone? Some think it's due to a synovitis posteriorly because there's micromotion. Who knows? But it's not due to overt instability that can cause a catastrophic neurologic deficit. And if you look at people that come into your office, they may not be healed at 9 months, they might not be healed at a year, but this particular study showed those not healed at a year, 80% of those people will be healed at 2 years after surgery. And the VAS arm pain relief scores are really no different at 1 year to 2 years. So it's interesting. And if you look across the entire literature of those who did not heal, there's really no difference in outcomes between people who have fused and not fused. And in particular studies, they've shown that those that have not healed have actually done better than those that have healed. What I do know is that you rarely operate on someone in your clinic who you've operated on that comes in and says, I'm doing great. You rarely offer them a repeat operation, and they rarely have recurrent arm pain. What they have sometimes is a throbbing toothache pain. The vast majority of people want to do nothing besides exercises, and the vast majority, 90%, go back to work. This was a fascinating biomechanical study where they looked at a created non-union model in a human cadaver. Then they did an anterior cervical decompression and fusion. Then they did an anterior posterior fusion, and they took the human cadaver and they did stability testing. And there's no significant difference between the stability between an ACDF, a non-union model, or an anterior posterior. So instability is not a major problem. And if you're worried about motion, why do we let athletes that have an anterior cervical decompression and fusion go back to contact sports? Case reports in wrestlers, case reports in soccer players, case reports in sports that have contact with the head, and you're having significant motion, and it was your intention to have motion preserved. If you look at studies that looked at anterior cervical decompression and fusion, they've done great when they return back to work. Take a look at this slide. Well, soccer, using head contact. Martial arts, using head contact. Skiing, you're falling down. You can go back and play. Military, wearing 20-pound helmets, go back to their work responsibilities weeks before someone who does not have such a strenuous occupation. So it's very common. And there's case reports in the literature. Take a look at this guy getting his head rammed into a wall. They play with a symptomatic non-healed fusion. This gentleman went on for 4 seasons with a grotesquely non-healed fusion with loosening of instrumentation. So there's no contraindication to go back to play. Oh, but you're worried about it, so you say, hey, listen, you're a contact athlete. Let's just be sure. Let's revise it anteriorly. Well, what is the risk of revising something anteriorly? Scar tissue, losing your voice, swallowing problem, recurrent laryngeal nerve dysfunction. Doesn't make any sense. Well, let's go posteriorly. You know what it's like to take an athlete's posterior muscle mass and spread it apart? Neck pain, inferior kyphosis correction, and they continue to have symptoms after revision. I always say to myself, if you want to have a revision posteriorly for pseudarthrosis, you have a 30 to 40% chance of coming back and giving me roses at the end of that operation. So does it matter if it's not unstable? The answer is no. If you have significant neck pain, you may not want to play, and that may be a reason to have surgery. But if you're not miserable and you don't have instability, I find no reason not to go back to play. So number one, no difference in functional outcome between someone who's healed and not healed. Number two, the biomechanics, it's micro instability. It's not a grotesquely unstable injury that predisposes to catastrophic neurologic deficit. And if you're afraid of motion, then why are all those crazy surgeons that put cervical arthroplasties allowing their patients to go back to sports? So in particular patients that have a non-healed fusion, asymptomatic, and I don't see significant gross instability, which you never see, I'm allowing those patients to return back to collision sports. Thank you very much.